Good evening, everyone, and thank you for joining us for tonight's Woo You event. Tonight, we have Dr. Kyle Ross, and he's going to be talking on integrative optometry and public health, connecting vision to headache, dizziness, and postural health. My name is Dr. Ariel Sorenzi, and I'll be your moderator for tonight. And a big thank you to Neurovisual Medicine Institute for exhibiting at this event. We'll get to hear from them at the end of our presentation, so please be sure to stay tuned for that. For CE certificates, please fill out the survey. The link will be posted in the chat and also emailed to you when the webinar ends. Attendees must be online for a minimum of 50 minutes for each hour of credit, so 50 minutes for tonight. CE certificates will be delivered via email and sent to ARBO with your OE tracker number. Please allow for about 4 weeks for those certificates to be emailed. They'll be there sooner. QR code will be displayed at the end of the event that you can use your OE tracker app to scan that QR code. So if you want to ask any questions, you can find the Q&A at the right-hand side of the page. That's also where the handouts will be. You'll see a little area that says handouts, so you can access the handouts there. If you want to minimize that, you can just use that little down arrow. And then if you want to open it back up, use the chat button. So it's my pleasure to introduce tonight's speaker and this interesting and awesome topic for tonight. Wisconsin native Dr. Ross earned his biology degree from St. Olaf College and graduated magna cum laude with clinical honors from ICO through the United States Navy Health Profession Scholarship Program. He went on to serve 3 years as a lieutenant in the United States Navy at the Captain James A. Level Federal Health Care Center in the Great Lakes, Illinois, where he served as the head optometrist and earned his fellowship in the American Academy of Optometry. Today, Dr. Ross brings that same dedication to his community-centered practice in Wisconsin, where he focuses on ocular disease management, neurooptometric rehabilitation, and dry eye care. What makes Dr. Ross's work especially impactful and what he brings us in today's presentation is his commitment to integrative optometry. He looks beyond the eye itself to understand how vision connects to the whole body, particularly in relation to headaches, dizziness, and postural health. His approach bridges clinical excellence with public health awareness, helping patients not only see better, but feel and function better. So we're so excited to hear your presentation tonight. Here are his financial disclosures, and I'll have you take it away from here.
All right, great. I don't see there it comes. Perfect, great. So this is a passionate topic of mine. I'm excited to share with you all about it. I could talk for days on this topic, and we have an hour. So I'm going to try it and kind of fly through this. A lot of this is in general review for optometrists, but I want to just see if we can stimulate a little different thought process on this and how we look at these patients, because these types of patients are in your chair every single day. So it's about being able to identify them and then offer them these unique services should you wish to take on the challenge. So as we kind of talked already, I'm located in Wisconsin. My practice, really since I got out of the Navy, has been focused a lot on vision rehabilitation and neurooptometric medicine. On my side, always had an interest in brain injury, in TBI, in concussion. But we found out as we kind of got into this world that it's more than just the injured patients that are dealing with binocular vision issues. I do also do some lecturing and teaching at Concordia University of Wisconsin right here in the Milwaukee area, and have done some teaching in the past, which I really enjoy. There's my wife and 2 kiddos. I have a 6 and an 8-year-old. My wife is a nurse practitioner who also teaches. So let's get right into it, just because we don't have a lot of time. So we talk about binocular vision dysfunction. This is a general term. Binocular vision dysfunction really has to do with the 2 eyes just not working well together for whatever reason. Could be strabismus, could be amblyopia. And what we're going to really focus on today is phoria. Generally speaking, BVD, binocular vision dysfunction, is present in about 20% of the population. So on your normal day, you're going to see probably 2 to 4 patients that have BVD every single day. In the brain injured population, about 50% of them are going to have some sort of binocular vision dysfunction, typically in the form of accommodative disorders, vergence disorders, and ocular motor dysfunction. When we look at binocular vision dysfunction, the symptoms are not always associated with eyes. So patients are going through this and they're not always able to really say, oh, I need to go to an eye doctor to get these things solved. So oftentimes they're going through lots and lots of workups. We see almost on the regular, patients have been to PT, they've been to OT, they've been to neuro, they've been to ENT, they've been to their primary care. They're searching for a solution to these problems. And eyes, unfortunately, are not at the top of the list for their answers. When we look at this today in this specific topic, we're going to talk about vertical heterophoria. We know there's lots of different types of binocular vision dysfunction, but when we talk about posture and what patients are most symptomatic, it tends to be vertical misalignment. So let's think way back to when we were in school. In those instances, when we were measuring vertical phorias, right, a lot of us may not have reached for that vertical phoria, that Maddox rod, or maybe we're not doing in-instrument testing anymore for vertical phorias, but trust me, it's not as complicated as it seems, and it is going to be a lifesaver for you if you're checking for these things. So specifically as a reminder, what is binocular vision dysfunction in the term of vertical heterophoria? It's a vertical misalignment of the eye. Either the physical eye is misaligned superiorly or inferiorly, or the line of sight, the eye is aimed slightly up or aimed slightly down. This is a great little image, from a patient education perspective. But what this is showing us as we look at this image now is the image on the right eye. That eye is slightly down, so the optic axis has an upward aim to it. The left eye is slightly elevated, so the optic axis has a downward aim to it. And just like we know with convergence insufficiency, the eyes are not aiming together, so we have to do work. When they have this vertical misalignment, our eyes are constantly trying to find that alignment, and it's much, 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 much more challenging to move our eyes in a vertical fashion for vergences, right, than it is to do horizontal. It's nearly impossible. So we can classify vertical heterophoria into two specific types. Monocular, this is what we often think about when we have our superior oblique palsy patients. It's not a binocular setup. One eye is involved, one superior oblique muscle, one side of the fourth cranial nerve is affected. In binocular vertical heterophoria, we're getting feedback from both eyes, generally coming from our vestibular system. So binocular VH is really much more of that, basically the feedback from our inner ear that's telling us, right, how our eyes need to move. Encyclotorsion, excyclotorsion, up, down, that vestibular ocular reflex. So it's generally a vestibular related issue that's leading to this. Here's just a quick summary on superior oblique palsy. We all know this pretty well. This is really dealing with one eye. So as you look at this child, it's their left eye that's elevated. When we have a weak superior oblique muscle, the eye is going to have a rise to it. It'll be slightly up and slightly out in that position. It also have a very difficult time being able to turn down and in. We know when we have this situation, if I can handle one eye, and classically we think of prescribing prism as splitting over both eyes. But in this particular case, when we're dealing with a monocular vertical heterophoria, patients tend to do best if we put prism just over the affected eye. In this case, we might have vestibular-like symptoms, but I'm much less worried about the vestibular system being involved as a problem child. The eye is primarily the problem child here. When we look at binocular vertical heterophoria, just to reinforce here, these are signals that are coming from our vestibular balance system, right? And they're telling our eyes to do the wrong thing. Again, with that vestibular ocular reflex, think about tilting your head to the left, tilting your head to the right. When I tilt my head to the left, my inner ear tells my eyes, whoa, we're off our visual axis. We're off the visual midline. So now my eyes are going to make these compensatory movements to straighten things out. When we're standing straight up and down, we shouldn't be getting that signal back. But in these cases, when we have binocular vertical heterophoria, we're getting that signal from the inner ear that tells us we're not upright, we're off to the side, we're not on our midline. And so our eyes are doing these reactive movements when they shouldn't be, and that throws us for a loop. In general, when we talk about vertical misalignment, we don't like it. Our symptoms are pretty significant. We put our body on edge. We tend to skew our system towards a fight or flight type response. And we see with binocular vision dysfunction, patients often are going to have this emphasized sympathetic nervous system response. And we can get into this a little bit more when we talk about dysautonomia. I don't know about you guys, but my practice sees a ton of POTS patients, a ton of patients with dysregulation between the parasympathetic and sympathetic nervous system. And if our eyes are not doing what we want, if we have a vertical misalignment, if our eyes are not matching with our surrounding feedback systems like our inner ear, that automatically skews our body to this state of discomfort on edge. And we'll see that in how we react into groups and large spaces and loud spaces. So what are some common symptoms? We all know these, right? When we have a difficulty trying to keep our eyes lined up, we can get visual fatigue, pain, frontal brow ache, right? We can have issues with balance, feeling like we're having visual motion sensitivity, dizziness. Dizziness is an interesting term. Patients don't always know how to describe it. So, when we are asking patients to describe their symptoms, sometimes they'll say lightheaded. Sometimes they'll see just feeling off-centered, feeling visual motion, right? They're not always going to say the room is spinning. They could just say, I'm on edge, I'm anxious, I'm not feeling right. Nausea comes along with that. Patients might report history of motion sickness, car sickness, difficulties, coming on and off of a boat when they're on a cruise. This mismatch between the visual and vestibular feedback does lead to anxiety. So oftentimes these patients are quite anxious. They have had doctors just tell them in the past, this is nothing, you just have high anxiety. Go ahead and take this benzo, right? Treat your anxiety and you'll feel better, and it doesn't. In some cases, these patients will have double vision, but in the vast majority of them, especially those that are hidden, they will not have double vision, or they don't know how to describe it. And almost to a T, they're all going to have postural issues. Their neck or their head tilt will be very present. So they'll have shoulder pain or neck pain along with that. These classic binocular vision symptoms we all know: poor depth perception, double vision, shadowed vision, that ghosting diplopia that patients will talk about. If we ask that patient, how do you feel better? Sometimes they'll say, I just cover an eye, or I close an eye, or when I'm reading, I tilt my head. These things we know and we see. Reading symptoms, we can have binocular vision dysfunction at any age. Of course, in our pediatric population, vision and learning is a big piece, and making sure we're correcting any sort of binocular misalignment is very important in the children's success with school. So these, again, are pretty classic symptoms for optometrists to know, but we don't always, from a patient perspective, understand that these are related to how we're seeing with the two eyes. Losing place when we read, fatigue with reading, skipping words, letters, lines, rereading, poor comprehension, slow reading speed, needing more time. And these are very frustrating things. So as a quick checkpoint, as you all enjoy my lady who has vertical double vision there to the right, you must have diplopia to have binocular vision dysfunction. That statement is false. Most of these patients, right, are not going to see double. If you put a number on it, it's about 2/3 of these patients that are symptomatic binocular vision dysfunction patients not seeing double. They just are not having their eyes work together, and that's creating a ton of stress on the visual system. If we get into more specifics, right, the obvious ones are the tip of the iceberg for us. We know that the classic symptoms and the reading symptoms in the classroom we just talked about. A lot of times, even as optometrists, we're not thinking of some of these other deeper issues that we're going to uncover with binocular vision dysfunction. Pain, in particular, headache. We talk about headaches a lot in eye clinics. Sometimes it makes us want to run the other way. A headache differential is very confusing. We need to feel comfortable with managing headache. We need to feel comfortable with breaking down the symptoms and also being able to refer that patient to appropriate management, imaging, et cetera, when necessary. So getting comfortable knowing about these symptoms. TMJ pain, right? That can also be another sign of binocular vision dysfunction. When we talk about BVD, the trigeminal nerve plays a huge role in sensory feedback, that pain feedback. We have our 3 branches of our trigeminal nerve, our ophthalmic, our maxillary, and our mandibular, right? Mandibular, TMJ, that's that pain coming from referred issues, possibly from our eyes. Doesn't necessarily have to be, but possibly. Neck ache, eye strain, sinus pain, pain with movement, we'll keep on rocking. Sensitivity to patterns. If any of you have some interesting carpet or tile in your office, if we're going to start managing these patients, this is an important thing for you to address ahead of time. These patients can have visual motion sensitivity that is set off by patterns or different lights or different smells. So we have to be aware that photosensitivity, visual motion sensitivity, glare, they can all set the patient down a spiral when we're evaluating them. The words vibrating on a page is an interesting one. That is almost exclusively an indicator of vertical heterophoria. That's your eyes jumping back and forth between the top eye and the bottom eye, trying to figure out which one to listen to, and your brain's just bouncing back and forth between the two. So if anybody is describing their symptoms as words vibrating on a page, we got to think about vertical heterophoria right away. The vestibular system symptoms are probably the most disturbing to the patient and also the most frustrating. They will likely have had some interactions with ENTs. They will likely have had some interactions with physical therapists working on their vestibular symptoms. And unfortunately, they're going to be stalled or not progressing because we're not addressing a key piece of the puzzle in eyes. When I give my lectures to physical therapists and my ENTs that I work with to give them background on this, I always tell them that if they have a patient who's not progressing and they can't figure out why they're not progressing, we definitely have to look at the eyes. In some cases, we have a true vestibular issue like 3PD, where we're having this physical therapy that can be done to help reset. They can go to an ENT and have their crystals reset, and we solve the issue with their vertigo, whether it's acute or chronic. But if it's binocular vision related, they're not going to progress like they're expected to. And it'll be very frustrating for the physical therapist. It's very frustrating for the ENT. They don't know how to solve these problems. And checking on the eyes can be that secret sauce that helps them progress. We see this as well with our acquired brain injury, traumatic brain injury patients, stroke patients, etc. So these vestibular symptoms are probably the most devastating ones and the most frustrating to patients. And if we can start to make them feel better, they're going to absolutely love you for it. Another area that we see a ton in this patient population is that they have some pretty significant psychological stressors. They're usually very anxious. They're not trusting of doctors. They've seen lots of doctors and they haven't gotten help. They have difficulty just getting in the car, coming to see you and schedule an appointment. They've had eye exams before. Their past eye doctor has not solved their issue. They're going to be skeptical about what you want to do or how you're going to do your testing. They're skeptical of glasses. So we have to be, when we're working with these patients, very cognizant of their psychological stress and to be open to a more prolonged exam experience, right? We can't hurry these patients along. We have to really build their trust, and we have to design our exam around that so that they can relax and we can really get true effective readings with them. But I think a big one here that is a hallmark sign for binocular vision dysfunction is difficulties walking down a grocery store hallway, right? The grocery store aisle phenomenon, that's that visual motion sensitivity where our central visual processing and our peripheral visual processing, what we call our ambient visual system, is unbalanced. And so as I'm walking down that aisle, all of the items on the aisle that are stationary, when I walk by, there's movement to them. And if my peripheral visual system, my ambient visual system, is too dialed in and too stimulated, I'm going to sense all that motion and get dizzy. So the grocery store phenomenon is a big thing. They typically have difficulty at places like Costco. They have difficulty in large, loud settings. There's some sound sensitivity, which we'll get to in a moment. Driving, they're usually going to either say, I have to be driving the car or I have to be a passenger, and they'll not like one or the other. If they can handle driving, they can't handle being a passenger. If they can handle being a passenger, they don't like to drive. And this can set off, of course, significant panic attacks. So the psychological aspect of treating this patient population is a big one. As I mentioned, these patients, it takes a lot to gain their trust. Typically, they have been searching to solve their issues. And on average, we see that these patients have been through the ringer a little bit, 4 to 7 different professionals before they get to us, before they get to an eye doctor who specializes in breaking this sort of situation down. Some of the prior diagnoses that we see, and if you get into treating this population, it's like a book. They keep coming and they're the same, and you see these over and over and over again. When you're doing your case history, when you're looking through your review of systems, you're going to see these things pop up. Oh yeah, as a kid, I was told I had dyslexia, or I had difficulty reading. I've been treated for vestibular migraines. I've been treated for vestibular neuritis. I have positional vertigo, BPPV, migraines, chronic neck pain. I've told that I had anxiety, right? Psychiatric wise, that's a big one. In some cases, right, we get this 3PD or this psychiatric dizziness, which is really, really a tough one to treat. In these cases, if we have these things that are going on, we're allowed to have more than one thing. It's important to know that the binocular vision dysfunction piece is only one piece of the puzzle. We're not necessarily going to solve all of these different diagnoses that they've had by aligning their eyes. Not at all. But we're going to help control the environment. We're going to control the feedback to the central nervous system, and we can start to see these symptoms improve. So I think that's a key point when we're treating these patients, because they're already on edge and they've seen a lot of different providers. We don't want to be promising the moon to them. We don't want to say, oh yeah, you have this binocular vision dysfunction. I'm going to give you glasses. We're going to do vision therapy and solve all of your problems. No. The goal of treating binocular vision dysfunction is to improve feedback to the central nervous system and calm down their symptoms. In some cases, it is just purely eyes. Those are fun. Patients absolutely love it. But in other cases, we have these complexities going on, and we're just part of the co-management team. It's an important part of the puzzle, but when we treat the binocular vision dysfunction, we're not going to solve everything. We're just setting them up in an environment for them to succeed better, and they will function better. And we can measure that. Hopefully, all of you that are listening to this are on board so far with what I've been explaining, and you can think of patients that you see on a regular basis that have these types of symptoms or this type of medical background. Certainly since COVID, back in 2020, we have seen a ton more of dysautonomia, POTS patients, and this certainly, I think, has a growing connection. We need specialists like you, right, to help out and treat this patient. I showed you this image before, but if we have vertical misalignment of the eyes, this is that simulator. Just try looking at this picture. It's very difficult. We do not respond well to vertical diplopia. Our brain does not like it whatsoever. So if we're walking around constantly trying to take a vertically separated image and fuse it together, we will be uncomfortable. Is there anything that can trigger or worsen their symptoms? Well, absolutely. Visual motion. So if we are having problems with vertical misalignment of the eye and I ask your body to move in space, that's going to be a challenge. When we're assessing these patients, we ask them, if you turn your head side to side, does that make your symptom worse? If you raise your head up and down, does that make your symptom worse? Bending down to tie your shoe, standing up. We're rating all these different activities and seeing how it affects their system. When we're evaluating these patients, we're also moving them. We have them stand. We ask if they feel any sort of sway in their body or movement in their body. Is it different when we open our eyes versus when we close our eyes? We have them walk down a hallway. We have them walk down a hallway with moving their head. It's a very physical examination because we want to see how your body responds to movement. And then when we align the eyes, we'll have them put trial frames on and we'll correct the misalignment with microprism. Then we move them again, and it's really interesting and fun to see how they respond and move in a better situation when their eyes are lined up. Oftentimes, again, these patients will struggle with these activities. They can't, for a while, I would say probably 15 years ago, 3D TVs were huge. That was great for the binocular vision world because it really identified patients who had problems because they couldn't see with these TVs. They're kind of dead now, but 3D movies are still a problem. Depth perception, right? Difficulties with reading, certain wallpaper patterns, carpet patterns, as we talked about, can set them off. Driving is a big one. A lot of my patients, they'll come to me and their goal will be, I want to get to be able to drive in a car again. That's crazy to me that, that's that impactful to their life. But if you treat and help them perform better and can get them back into a simple task, such as riding in a car, they're going to love you for it. We talked about this, so I won't spend too much time. The grocery store phenomenon on the left, or the large crowds as far as setting our system off. Remember, these patients are already in a skewed situation towards the fight or flight response, right? So now when we challenge the rest of our sensory system and we put them in a very uncomfortable situation, they're going to be much, much more set off. Causes of BVD. Well, we can be born with it, right? We can have just this physical separation, whether it's monocular or binocular. We can have it just exist for our whole life. It's interesting, when we are born with it, typically we do a pretty darn good job of handling it and compensating for it, unless we have a significant life change event, like a car accident or a TBI or a concussion. Now we've taken that compensation and thrown it on edge. So a lot of my patients are in their 30s, 40s, 50s, and they were completely asymptomatic in their life. And then some event happened. They were sick, they were hospitalized, they were in a car accident, they had a concussion, and now they're much, much more symptomatic. TBI is probably, it's my favorite type of patient to treat. All of these patients, I know it's crazy. All of them have some sort of vision issue to begin with, and it often just gets poo-pooed by the concussion team. So if you get involved with binocular vision management, make sure you start and educate your docs that you work with, your pediatricians, your primary cares, your OTs, your PTs, your rehab professionals, that you're there to help out with these concussion patients and TBI patients, as well as stroke. That's another large group of patients that I treat. We can do things with visual fields. We won't get into that a whole lot today, but stroke patients are another really great resource or group of patients to treat, and the physical therapists, the occupational therapists are really great resources for referrals. So the recurrent themes, we talked about this. They're symptoms that they're not recognizing as related to their eyes. They're used to going to their eye doctor, which is clear 1 or 2, getting a pair of glasses, and away they go. These patients have been symptomatic for a long time, generally speaking, and they have gone to many different providers. Because of that, they're frustrated with the system. They've had many tests performed. Sometimes we're talking about super expensive tests, and in some cases, they're just trying everything, throwing everything at the wall to see what sticks. In the end, these patients, their history is, I've tried all this stuff and it's not working. And it's usually because the binocular vision piece, that select piece of the puzzle, has not been solved. And in the best cases, once you solve that, symptoms resolve. So how can you, as a primary care optometrist, quickly screen for this? Well, there's some really great tools. I think the easiest one to screen for, if you have it, would be access to the BVDQ, or the Binocular Vision Dysfunction Questionnaire. It's a really quick and dirty way to go through all of what I just did in the last half hour in about 5 minutes for the patient, and it'll make you feel real comfortable that this patient has some form of binocular vision dysfunction. Another quick way to screen for it is something called the 5-minute cover test. I recommend this one for my physical therapist and my occupational therapist. And then the near point of discomfort, again, that's another one that's good for your non-optometry professional. So let's get into each of those. The Binocular Vision Dysfunction Questionnaire is by far, I think, the most helpful tool. I know we're inundated with questionnaires. When I first got going with binocular vision dysfunction treatment, I'm like, I don't want another questionnaire. I don't want another questionnaire. I got a questionnaire for everything, especially because I do a lot of dry eye as well. But this is super helpful because it asks the patient very distinct questions, and it also has them grade their symptoms. And anytime you're treating a patient, you want to be able to show them, here's how you're improving. Because sometimes they don't feel like they're improving, but if you're able to show them these sequence of questionnaires, these symptom scores, that can help guide them that, oh yeah, I am getting better. And then we can start that motivation to keep driving our success. So the Binocular Vision Dysfunction Questionnaire comes for different ages. This is one for 14 and older. We have symptom-based questions. On this first page, we're looking for a total score of 15 or higher, right? And we're going to ask them, is this always, frequently, occasionally, or never? And how we kind of grade that is, never gets a 0, occasionally gets a 1, frequently gets a 2, and always gets a 3, right? And then as we're totaling them up in each column, if they score 15 points or higher, there's a really strong likelihood that this patient would benefit from binocular vision treatment. This has been written up in the Journal of Otology and Neurotology. This is the ENT doctor who specializes in dizziness. So a huge, really big win for optometry to get this written in such a nice, prestigious journal in a different specialty about how successful it is at identifying patients with these issues. On the back, right, there are also some additional questions. I don't see them here. I think I got it in another slide. I'll show you in a moment. This is a different age group. We want them to get more specific, right, regarding their symptoms the older they get. So in the younger group, it's much less of a detailed assessment. We all go down all the way to a 4-year-old for the parents just to ask yes and no. So depending upon the age, can be a very helpful tool. As I mentioned before, a score of 15 or above is highly predictive, and will say, hey, you know what? I bet I can make you feel better if we get onto a specialist to deal with this, or if we start treating these problems. On this BVDQ, I'm going to bump back just a touch. If we go back here, this is one that I recommend using for the general optometrist who may not wish to really dig into this too much, but they want to screen for patients and refer it on. I also give this basic BVDQ to my OTs and PTs, my pediatricians, my internal primary medicine docs that I work with, because it doesn't get into the weeds too much. There is a longer BVDQ if you start treating binocular vision dysfunction that also gets into some other potential systemic issues that you want to deal with and get referred for management, namely the dysautonomia that we've talked about already, maybe some inner ear dysfunction things like third mobile window syndrome, where we have the semicircular canals basically not working like they should. We get into sound sensitivity, hyperacusis, tinnitus. These are other things that are going on with the patient and sometimes require referrals to get addressed. So if we really start treating binocular vision dysfunction, this questionnaire can get a whole lot more complex. But this form right here is great to start with. Now, another really good way of assessing if your patient is going to feel better with binocular vision treatment would be the 5-minute cover test. This simply asks the patient to rate their symptoms, how they're feeling before, and then they cover an eye, right? They cover an eye and basically cover an eye for 5 minutes, and then we ask them to rate their system again. By taking an eye away, if we have binocular vision dysfunction, by taking an eye away, we should feel better. And it takes about 5 minutes for our system to kind of calm down and relax. This is exactly what patients often do at home by closing an eye or covering an eye. I don't think this test is real great for optometrists to do. I think we are capable of doing more specific tests like the Maddox rod to look at vertical heterophoria to screen for it or not. But for your referral partners, your pediatricians, your OTs, your PTs, this is tremendous. It's very easy, and it's easy for the patient to do. Again, this near point of discomfort, not the greatest for optometrists to do, but when we're talking to our referral partners, this is a really easy way to kind of screen for convergence insufficiency, for difficulties with binocular teaming. Easy to see if patients are symptomatic. All right, physical findings. This person, we can look at her and say, yep, she's got some vertical misalignment of the eyes, right? So in some cases, right, we can see there's a distinct facial asymmetry. That's where we should be lined up. Some patients will have a head tilt, right? Head tilts are very pathognomonic for vertical heterophoria and binocular vision dysfunction. Remember, we're going to be kind of tilting away from the high eye. So in this situation, she's got a head tilt to her left shoulder. So I'm suspicious that the right eye is the high eye. So now, are we dealing with a superior oblique palsy? Maybe. Are we dealing with a superior oblique weakness? Maybe. Are we dealing with potential misfeedback or faulty feedback loop from the inner ear? Maybe. We don't know. So we have to do some further testing to figure that out. But a head tilt in pictures, photos, as you're having a conversation with the patient is very, very distinctive. Again, we talked about the neck and upper back pain from the posture and the head tilt. The inner ear findings, we will have the patient walk, right? So we have them stand and we have them feel, okay, are you steady when you're standing right now? Eyes open, feet underneath you. Do you feel any sway in your body? How about with your eyes closed? Do we feel any sway side to side, forward or back? That can be a good indicator. If eyes open, we feel good, but eyes closed, we feel bad, that we might have some inner ear feedback and the eye and the ear aren't cooperating, and vice versa. Having them walk, watching them walk down a hallway, watching them walk with some head movement, super effective. Now, we are not physical therapists. We are not doing gait mobility assessment to the nines. We're just looking for any sort of drift. Do they have a shoulder tilt, head tilt? Are they off steady? Very gross assessments with our gait analysis. We can ask them move their head in different scenarios. I like to have them move their head side to side like they're saying no, up and down like they're saying yes, tilting from ear to ear on their shoulder, bending down, tying their shoe, and sitting up. Those are all great ways to see if we can elicit vestibular reactions. Oftentimes, these patients will have sound sensitivity. And this goes back to the connection between the eye and the ear. We are all aware of the vestibular ocular reflex. And if the ear is telling the eye one thing and the eye is telling the ear one thing, and those systems are not lined up, both of them are not going to be feeling too good. And when the inner ear is upset, sounds are extremely bothersome. So this patient population oftentimes will have sensitivity to noise, and we can calm their symptoms by doing noise canceling. So during our exams, we will have patients test out different noise canceling devices if they are expressing sound sensitivity to help calm that feedback, right? Calm the balance between our parasympathetic and sympathetic, get that fight or flight response down. And patients, generally speaking, when we have binocular vision dysfunction, will do really well with sound sensitivity. Noise canceling devices for their sound sensitivity. Oftentimes, as you're asking them, they'll be like, oh yeah, I use these. I use loops. Loops are very popular on social media. Now we've talked about it and you're all online right now, that'll pop up on your feed, but loops are kind of like an elevated earplug. Another one that I like are called ear planes. Ear planes are great for if you have popping ears on a plane. That's why they're called ear planes, but it also does nice at filtering sound down. Loops, ear planes, earplugs, those are passive. We also have active noise canceling devices like you see what this patient is wearing, or AirPod Pros, we can turn on the noise canceling. And some patients do extremely well and feel much, much better and much, much more relaxed when they have the noise canceling done. So what does it generally look like when we treat these patients? Well, we're not going to do binocular vision assessment on a regular comprehensive exam. We just don't have the time. These patients require a lot of hand-holding, a lot of psychological support. And so we can screen, right, using the binocular vision dysfunction questionnaire, using our case history, using the Maddox rod if we're suspicious that there's some misalignment going on. We can screen for them at our comprehensive exam, but we're going to need to have them back for an official assessment. And typically, I will book about an hour to an hour and a half for the initial evaluation, because it takes time. We got to work through it. We can't speed them. We need to make them feel comfortable. We're going to have them move, walk, dance, all that stuff, right? So that first visit is going to be about an hour and a half. I'll then prescribe my initial course of treatment. Generally speaking, and at my practice, I do vision therapy as well. But generally speaking, we're going to get a proof of concept by aligning the eyes up using microprism. We're going to take that vertical heterophoria and eliminate it. In some cases, we'll also address, to some extent, horizontal deviations if we need to. And then we're going to give them glasses, have them wear them for about a month, and have them come back and reassess their symptoms. We'll go back to that binocular vision dysfunction questionnaire. We'll rate their symptoms, and we'll see how we're doing. In most cases, we see a 30 to 50% improvement just from lining the eyes up and wearing the glasses. From there, we'll get some progressive relaxation of the visual system. Usually the first time we see that patient, they're very tense. Their system is really compact and they're fighting. Their eyes are trying to solve the issue on their own. So as they wear their first pair of glasses, typically their symptoms will improve. It might stall, and it might even go a little bit backwards by the time I follow up in about 4 to 6 weeks. So then I'm going to reassess their alignment, reassess their symptoms, make adjustments to the prisms if I need to, and then prescribe that next level of treatment, which in some cases is not needed. the glasses solved everything. In some cases, it's moving on to doing some vision therapy to make the visual system more flexible, to increase stamina. And in other cases, it's getting another professional involved in co-management. The key part, I think, in the initial evaluation is your history. You got to have a good team, either a tech or a scribe who works with you to get that detailed history down, because their symptoms are really going to guide you. We've all done the physical evaluation of the binocular vision system in school. Maybe we haven't gotten back to it since we've been on practice on our own. But working with a light box, working with cover test, working with FORIA assessments in instrument and out of instrument, working with Vergence assessment in instrument, out instrument, breaking out that prism bar. These are all part of the workups, and we can all relearn how to do it. But the key is give yourself time, go slow with these patients, and you can really make a big difference. Typically, we will focus on microprism. We do a lot of work with filters for light sensitivity. In the migraine world and in the brain injury world, FL41 is a light rose tint. We've probably mostly heard of that already. We prescribe a lot of that. Avalux, you've probably heard of for migraine, is an excellent filter. Omega Blue, another really good one. Blue filters for screens, transitions, sunglasses, etc. You can really start to prescribe these glasses like medicine. And that's probably my favorite part about treating binocular vision dysfunction. When I prescribe glasses, these are just not glasses that you're going to go online and buy and the patient's never going to come back. These are medicine. You're prescribing glasses for a medicinal purpose, and the patient knows that. We're educating them. We have them try on in trial frame a setup so they can feel it and experience it while they're in the office. And then when we write the prescription, we know it's going to work. Prescribing glasses for medicine versus just power, so much more powerful. It's probably my favorite day. I do 1 day a week, every week on neurovisual, because my exams are an hour and a half long. I dedicate a whole day to it, and I see between 8 and 10 patients in that day. But it's the easiest optical handoff. It's the easiest how we, the interaction with the patient and recommending the lenses. It's the easiest day I have because I'm prescribing for a particular medicinal reason. You need this tint, you need this level of prism, you need this type of lens. And it's very easy. The patient hears that, this is what I need, this is my medicine, this is what I'm getting. So I really like that part about this specialty. We talked a little bit about this. You guys should all be familiar, but this progressive relaxation concept, right? When we have binocular vision dysfunction, this vertical misalignment or horizontal misalignment, we're trying to solve that on our own, right? We're trying to compensate. We're trying to get these eyes going together. This is often why we're so symptomatic. This is why the trigeminal nerve gets flared up. And so when we prescribe that first set of prism to help relax and take away that work, that patient may be hiding a larger deviation. And so as we wear the initial glasses and we come back, we want to reassess. As things have calmed down and symptoms have improved, do I need to adjust that prism? And in some cases you do. It's not all the time. I would say, anecdotally in my practice, when patients come back, maybe 15 to 20% of them require some fine tuning. And that's what the progress assessment is for. Again, really, when we get into this specialty, you want to always grade symptoms because that's going to be your key to the next steps of our treatment. So we look to say, okay, how much have our symptoms improved? I always like my patients to give me a percentage. I'm better 25%. I'm better 50%. That's also helpful if you're dealing with litigation. Some of these patients are dealing with car accidents. Some of these patients have had some sort of brain injury, whether it's on work or not. And so when legal teams look into this, percentage improvement is important when they're gauging how successful your treatment is. But again, in the progress assessments, we're doing in instrument, out of instrument, looking at binocular aiming. I'm also a big fan, and I don't have it listed here, but I'm a big fan of the, and I don't work for them or anything, but the right eye system for tracking ocular motor skills, fixation, and visual processing speed. The right eye system is fantastic, and I use that a ton with these patients. Big help when we're talking about vision therapy, big help when we're looking to measure not only symptomatic improvement, but an objective improvement on their ocular motor skills. It's really great to have. So some sort of computerized vision tracking software is, I think, a huge recommendation from me if you're going to start doing this. And then this is usually where I'll decide, okay, I want to move on with vision therapy or not. I have a unique practice. So we do a ton of pediatric vision and learning vision therapy. I do a ton of brain injury vision therapy, and I have an occupational therapist on staff as well as an occupational therapy assistant. So it's kind of cool. We get to do that co-management right here in our building. I realize not everyone has that set up, but it is a way you can specialize even further. And I find in general, OTs and PTs love this stuff. They love it. They love referring to me. They love finding out about it, learning about it. And I'm a big fan of teaching and showing them, the role that optometry has in co-managing these patients. And it's a really nice synergistic relationship. So usually at this progress assessment, that's when I will talk about vision therapy if needed. In general, I think 50% average improvement after the first exam. So we rate their symptoms, we prescribe their microprism, we have them come back, and most of the time it's 50 to 75% improvement. At the end, 80% average improvement when we release them. So remember, binocular vision dysfunction in some cases is just a piece of the puzzle. So we want to help them move in the right direction. We want to take care of the low-hanging fruit, the obvious stuff that has not been addressed, and will help them move in the right direction. But we may not solve everything altogether. But if we treat the binocular vision dysfunction, now we're going to be able to progress in our physical therapy, our occupational therapy. We're going to be able to progress at our work accommodations or within school. And so by making ourselves feel better, 25%, 30%, 50%, we give them a win. And these patients need to stack their wins. Oftentimes they are beat down. They're not confident. They haven't gotten the right answers. And when you can start making them feel better, now they open up. This is something that with the Neurovisual Medicine Institute, they showed me. These are not my patients, but I just thought this was really, really powerful. This was a patient who, they asked them to do a portrait before the binocular vision dysfunction, the microprism lenses were used. They did their exam, they put a trial frame on, and then they had them draw. So this is a patient now who in the beginning was not feeling very good, and now they're feeling much better. Things are lined up. They're spending more time on it. They're not avoiding the near work anymore. They're embracing the challenge, and they draw a really good picture. Again, another example. I think these just can be powerful. I use these in particular when I'm giving lectures to OTs and PTs, just so they can kind of see it, and it's a very powerful image. Now, as I mentioned, we're just one piece of the puzzle. So oftentimes these patients have seen many, 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 many different places. So we have to know, okay, where have they come from? Where are they going to? Where can I direct them to? And we do spend a lot of time with these patients coordinating care, sending letters, making sure we're getting everybody on the same page, aware of our treatment plan. One of the best things that I learned when I was in the Navy is these brain injury patients, we can't have them on silos. We have to be working as a team. And unfortunately, in medicine, out in the real world, these patients are coming from silos or hospital systems that don't communicate well with other systems. And so the more we can communicate amongst professionals, the better the care result ends up being. This happens to be ophthalmologists, neuro-ophthalmologists, neurologists, ENTs, PTs, OTs, audiologists, right? Chiropractors are a big source of referral. Dentists are a big source of referral with the TMJ. So our schools, our reading specialists, the connection is really endless. All right. So I blasted through all that. That was a lot to go through. Hopefully we drank with the garden hose there and we're surviving. We're surviving. But thank you for your time.
That was great. Thank you so much.
Mm-hmm.
There we have lots of questions in the Q&A area.
Awesome.
So we'll try to get through them as much as possible. There were several questions on microprism. If you could expand a little on microprism. Some of the questions were, what is microprism? Can you talk about it? What is the amount prescribed, and do you give it to both eyes?
Yeah. So I didn't really get into the specifics of treatment, but yeah, microprism is a way of aligning the eyes, and so there's different strategies with prism. Oftentimes we're talking like 1/8 of a diopter here, and we may have some familiarity, retail wise, like NeuroLens. NeuroLens, I do prescribe in my office. It's not my main form, but NeuroLens uses these really tiny amounts of prism. They have compensation for distance and near. I think it's a really great lens. When I talk about microprism, I'm not really meaning NeuroLens. NeuroLens is a set calculation. This microprism is you actually determining, okay, what's the deviation, measuring how the eyes compensate for that, and then dipping over small amounts, 1/4 to 1/8 of a diopter, determining primarily for vertical heterophoria, what I'm referencing here, vertical prism over one eye or over both. Do I have a monocular vertical heterophoria or a binocular? And then from there, we trial frame. So we put the prescription in the trial frame, and then we dip tiny amounts of prism. How do you feel? And we start correcting that vertical heterophoria, and we're just sliding prism in, taking it out. How do you feel? Next. And as the eyes line up, the vision quality increases. So we have the patient guide us as we're dipping the prism 1/4 or 1/8 of a diopter at a time. Is that clearer, darker, sharper? Is it clearer, darker, sharper? It's very much like a refraction, but it's a trial frame and it's lining the eyes up. So when we get them lined up, they go, whoa, that's so much sharper. That depth perception is better. And so you're pretty confident just from the trial frame on where to be. But it could be over both eyes or it could be over one. Last thing I'll say on that, I don't know about you, but when I was in school, I always thought you had to split prism over both eyes, and vertical had to be base up and base down over the other eye. And that's not the case. You can do vertical over just one eye and be very, very successful.
Great. And then there were a few questions about the questionnaires. What are the best places to find some of those questionnaires?
Yeah, so I believe the binocular vision dysfunction questionnaire is available online. I know Matt from the Neurovisual Medicine Institute, he might give you a little more detail on that and how to get it. But because it is, part of, it was studied and published in the Journal of Neurotology and all that stuff, right, with ENT, I believe you can access it online. I'm not sure. The only reason I'm not sure is, Neurovisual Medicine Institute has a ton of resources that they give to doctors who work with them. It is a group, a doctor group, where we can bounce ideas off of one another. And they gave me all that stuff. So it's great, but I'm pretty sure you can just Google it and access it.
Okay, awesome. And then last question that we'll have time for tonight is, when do you consider adding filters to patients' glasses, and which filter do you typically start with?
Yeah. So based off of symptoms is typically where I'm at now. As a pediatric practice, we also do some kind of interesting filters, right? Just to ease some anxiety and calming, right? But mainly for our binocular vision dysfunction patients, do they have a history of headaches, migraines, light sensitivity on screens, light sensitivity outside? And I will very subjectively give them the different filters. I have flippers. So I always start with long wavelength. start with FL41, and I'll work my way down to the short wavelength, the Omega Blue. So FL41, we'll do Avalux, we'll do a standard Blue Tech Classic, Blue Tech Ultra, and then work down to Omega Blue in a blue-green mix. But start long wavelength down to short.
Perfect. All right. Well, thank you so much for sharing all of this knowledge with us. We have lots of interested folks tuning in tonight, lots of great questions.